Hello everyone, this is Kamran Popal and I've just gained a national training number recently, so I thought I should make these videos to help everyone and learn from what I've learned. I'm going to go over some emergency scenarios now. I would start off with some prioritization scenarios. In the emergency scenarios, they're very condensed scenarios, so they might be asking you a lot of questions. So you have to be precise, short, and be able to answer all the questions. And it's very important that you can prioritize it, put the key points out, and finish the station. So finishing the station is one of the most important things that you need to do in the station. So don't try to show off your knowledge so much or try to prolong the answer too much. If you've said the answer, you've said the salient points, move on. And if you don't know, move on. This is very important, and if you get to the end of the station, that would actually save you marks as compared to if you put too much time on one question and miss a few questions towards the end. So starting off with the first scenario that I have, or I've written in my notes. You're an ST3, you've got an F1, you get 3 calls. First call that you get is about a patient who's short of breath with SATs of 87%, respiratory rate of 30, and he had a PCNL today. Second patient is a patient call from the gynecology theatre or an obstetric theatre where they've caused a bladder injury. And the third call is from an angry A&E consultant where he says that there's a 50-year-old male with 12 hours history of testicular pain who is breaching, and the consultant is threatening to complain against you. You just need to have a way of prioritizing them. You will have your own way of doing it. I had my way of doing it. The way I said it was, there's multiple urological emergencies at hand. I would rationalize my skills as well as my team's skills to prioritize these cases safely. I would see the PCNL first and ask the nurses to start oxygen. I would call the on-call consultant to deal with the bladder injury and ask theatres to prepare any equipment that is needed. I would ask my F1 to see the testicular pain with guidance, and I will review afterwards. And I will call the A&E consultant, apologize for the delay, and explain the situation and the reason for the delay. This is the way I prepared my questions answered. And most of the prioritization scenarios, this is how you will be prioritizing them. The first question, how will you assess the patient who just had a PCNL? So I will assess the patient according to so these are emergency scenarios. So remember, you're using CRISP protocols and those sorts of things, and not just using the simple history techniques. Bear in mind, there's a gray area. Some emergency scenarios you might want to have a little bit of a quick history, but also say that I would use the CRISP assessment and this and that. So I would assess the patient according to the CRISP protocol from A to E, and also review the operation notes for any complications. In particular, I would start 100% oxygen, check respiratory rate and saturations, examine the chest, request a chest x-ray, do an arterial blood gas and an ECG, and that's it. So it's a very quick and short answer, but you've said the main bit. And then if they ask more questions, you can elaborate that, but you don't have to say CRISP A, B, C, D, E. You already said that CRISP protocol from A to E, and also review the op notes for any complications. In particular, I would start this, but that's it. And then he'll move on, okay, what's your differential diagnosis? And you can say, number 1, pneumothorax. So obviously he had a PCNL, so number 1 is pneumothorax, PE, atelectasis, pneumonia, cardiac causes such as myocardial infarction. And you can link that with the things that you ask for, chest x-ray, EVG, ECG. So these are the differentials that are coming into your mind. So chest or heart. Okay, so chest x-ray shows a pneumothorax. What is your management? So if the patient is unstable, you need thoracocentesis, call the respiratory registrar to come and do a chest drain and stabilize the patient. Otherwise, you can just call the respiratory registrar for a chest drain insertion. Escalation of care can be mentioned over here if the patient is unstable, but the first thing that would stabilize the patient would be doing a thoracocentesis with a 16 or an 18 gauge needle. Okay, so there's a question about where you do that. The older ATLS guidelines were second intercostal space, mid-clavicular line. The current guideline is mid-axillary line in the fifth intercostal space, between the fourth and the fifth intercostal space. Then they can ask you about testicular pain differentials. So we'd always rule out testicular torsion, but in a 50-year-old, it may be epididymoarchitis, scrotal abscess, inguinal incarcerated or strangulated hernia, hematocele or trauma, rupture of testes, Fourniers. You can say differentials all day long. So as far as you've got the 5 basic ones, that's fine. If you're being pressed, then that means you're doing very well. So other differentials: epididymal cyst, thrombosed varicocele, hydrocele, sperm granuloma, testicular cancer, VUJ stone, urethral stone, prostatitis, scrotal cellulitis, Fournier's mumps, IgA vasculitis, torted hydrator of Morgagni, chronic or neuropathic pain. There's so many differentials you can say, but when you're put on the spot, sometimes you forget. So if you know all of these differentials, always say the first 5 important ones, and then if they press you, then you can just go on and say everything, and then they'll know that you know everything about your testicular pathology. Okay, so if the temperature is high, white cell count and CRP is high, ultrasound shows a scrotal abscess, what is your management? So you say, okay, I'll prioritize this patient, ask the patient to be kept nil by mouth. I would request some OBS and bloods. I would assess the patient according to the ABC and ABC CRISP protocol, and ensure sepsis 6 is established with oxygen, IV fluids, IV antibiotics, blood cultures, urine cultures, lactate and catheter. I would then take a brief history, asking for the onset, duration and progression of symptoms, associated lower urinary tract symptoms, especially infective symptoms and temperature, and also any risk factors such as immunosuppression in the past medical history, diabetes mellitus, HIV, steroids and alcohol, also any medication such as anticoagulants or allergies, past surgical history of urological instrumentation or long-term catheter, and a social history looking for performance status, baseline mobility and fitness for surgery. Then I would move on to examining the patient, doing an abdominal exam for a palpable bladder or percussible bladder, urogenital exam, a perineal exam, and then discuss with my consultant. Okay, so next question. Okay, this is a random question that has come in between. You see nurses talking loudly about patients in the corridor. How would you handle this situation? So this is just take them into a quiet place, understand the reasoning for doing this, remind the nurses the importance of patient confidentiality, and if this happens again, you can escalate this to the matron. Moving on, okay, so it's gone back to the testicular scrotal abscess question. So there's a 1 centimeter necrotic area in the scrotum and there's cellulitis extending into the perineum. What are your next steps? So there's multiple steps. You can first of all say, I'm concerned about Fournier's gangrene, and henceforth I'll keep that patient nil by mouth and inform my consultant. I would call the microbiologist and cover the patient with broad spectrum antibiotics, which is usually triple therapy. So you can use meropenem or dalzacin plus clindamycin plus vancomycin, covering gram-positive, gram-negative and anaerobes. And inform the emergency theatre coordinator, anesthetist for CPOT, book a category 1 surgery for wound debridement plus minus urinary diversion plus minus fecal diversion. And CT abdomen pelvis can be considered en route to theatre if this does not delay the surgery and if the source is unclear or expected to be within the abdomen. You can also mention plastics here, but plastics don't get involved up until later on, where the patients usually need flaps and stuff, but we can mention that. Also, you need to ensure that you've called for a general surgical review, ITU CCOT review, etc. So define Fournier's gangrene. So what is Fournier's gangrene? So Fournier's gangrene is a life-threatening form of necrotizing fasciitis affecting the urogenital area, the perineum and the perianal area. And it is associated with 20% mortality and worse outcomes in diabetes, alcoholics and colorectal source of sepsis. And then they say, what are the organisms which cause Fournier's gangrene? This is a polymicrobial infection with usually 4 organisms grown. The aerobic aneurysms include gram-positive such as Staphylococcus aureus and epidermidis, Enterococcus, Streptococcus faecalis and beta hemolytic streptococcus, and gram-negative such as E. coli, Klebsiella, Pseudomonas proteus, anaerobes such as bacterioids, Clostridium perfringens, Fusobacterium, and others such as Candida and Mycobacterium. Then we've got a question on what are the principles of surgical management. The surgical management is debridement of the necrotic tissue till healthy tissue is reached, then protection of the wound with urinary or fecal diversion, then relook in 24 to 48 hours, and lastly, plastic surgery referral once the sepsis has settled for grafts and flaps. Then another question is, orchidectomy normally needed in Fournier's gangrene? No, it is not needed because the cutaneous compromised supply is separate to the supply of the testes, which comes from a different source or a different compartment. Or actually, say it like this. Usually, no orchidectomy is not usually needed. Testes have their own blood supply independent of the compromised cutaneous or / facial circulation. Scoring system. So the scoring system for Fournier's gangrene is your Loire system or Loire et al. System, also known as the Fournier's gangrene severity index. They were, in one of the interviews, I heard a candidate telling me a few years ago that they were not looking for the Fournier's gangrene severity index. They were actually asking about the Loire. They wanted to hear this name of the person, so Loire et al. System. Et al. I'm mentioning because this was basically a very famous paper written by Loire et al. And many other authors. So it's called the Loire et al. System, but you can also say the Loire system for Fournier's gangrene severity index. And just so you know, this is 9 parameters with scores between 0 and 4, and if the score is greater than 9, the mortality is 75. The parameters include temperature, heart rate, respiratory rate, sodium, potassium, creatinine, hematocrit, bicarbonate, and white cell count. Right, so this is the end of the first emergency scenario. We will come to the next prioritized incident scenario in the next video. I wish you the best of luck and hope you're benefiting and enjoying these videos. Take care.